Ladies and gentlemen, Honorable Chair, it is my pleasure to present to you the first fresh and crispy data from the chronic pancreatitis data collection from the pancreas registry. Everybody mentioned that the pancreas registry is still in baby age. So the aim of the presentation is to try to highlight on the difficulties and the possible problems of the data collection and try to improve our data collection. And if it is possible, try to figure out and find some correlation between the data which can improve our diagnosis and treatment in the chronic pancreatitis patients. Already mentioned several times, we have altogether 14 cities with a lot of centers collecting data. We have altogether 229 patients from the previous 2 years. Let's jump immediately to the data because we have several excellent presentations about the chronic pancreatitis genetics and pathophysiology. So it's better to talk about the clinical data. It's not a surprising slide. In Hungary also, the alcohol consumption has quite an important factor in the etiology of the chronic pancreatitis formation. More than half of the patients has some influence of the alcohol consumption. The biliary etiology is almost the same compared to the literature. The last bar is the I called unknown. That is the possible pitfall of the data collection. I'm not brave enough to talk about idiopathic pancreatitis. There are several cases where, because of the lack of the data collection, we are not able to determine the etiology of the patient because it would be too big number if we think that it is idiopathic. The gender predisposition is absolutely according to the literature, 74% males, and the median age was 54 years. Back to the risk factors again, the alcohol consumption means a very important risk factor in chronic pancreatitis formation. 2/3 of the patient drinks regularly or occasionally alcohol. It's the same with the smoking as well. More than two-thirds of the patients smoke cigarettes, more than 10 cigarettes per day. We are able to discover family predisposing factors less than 3% among these patients. The genetic tests are missing in 95% of the patients. Of course, it's not a big deal because it has some sense only in idiopathic and hereditary pancreatitis, and probably this 5% is connected to that group of the disease. What is really important that as I mentioned, this registry is working as a cross-section of the treatment of the patient. So the patient has some previous history about the disease. So it's important to talk about the previous hospitalization due to acute SHUBs, which was really, really high. We have a presentation about the importance of the recidive acute pancreatitis in chronic pancreatitis formation. It's correlating with the literature. 30% of the patients had already endoscopic and 30% also surgical intervention before this admission to the hospital. The majority of the endoscopic intervention was just an ERCP and an EST. In this setup, there was no any Wirsung stent implantation in the previous history of the patient. These are the typical surgical interventions. Decompression operation, surgical drainage, and resection was the most frequent intervention. Interestingly, pain is just in 22% present in the patients with chronic pancreatitis, fever in 12%, jaundice in 11%. What is probably interesting that the clinical signs of the exocrine insufficiency, means steatorrhea or diarrhea, is 13% present, and more than 10% weight loss is in almost 40% of the patient there. Endocrine insufficiency is 33%. What kind of imaging techniques lead us to get a diagnosis of chronic pancreatitis? The most frequent one is the ultrasound examination, and cheap and less invasive, of course. CT scan is also quite frequent, but the MRI and the endoscopic ultrasound is not a real available method, unfortunately, in that moment in Hungary. I want to highlight this number. Diagnostic ERCP, almost 40% of the patients. Regarding to the literature, it's an unacceptable high number. So if there is one take-home message of this presentation, then probably this one, diagnostic ERCP. If there is any other possibility in Hungary, would be better to decrease. The functional tests. Only 5% of the patient has breast test performed, and no any secretin-stimulated MRCP, no any functional endoscopic ultrasound, and no any fecal elastase test was performed. It is important because in Hungary, the rule of the prescription of enzyme substitution is absolutely connected to a positive functional test, but the clinic is not the same. As you could see in the previous slides, a lot of patients has clinically manifestation of exocrine insufficiency, so that means that they need some enzyme substitution, and according to your results, 57% of the patients get some enzyme substitution, which is probably less than really necessary according to the clinical symptoms. Jump to the therapy. I was talking about the exocrine insufficiency. 1/3 of the patient has endocrine insufficiency. Also, the majority is treated with insulin or with oral antibiotics or a combined treatment. If I'm talking about the endoscopic intervention, not in the previous history, but what was the cause of the hospitalization, we can see that the majority of the patient was after an ERCP and an endoscopic sphincterotomy. There's a small number, relatively small number of Wirsung stenting also, and thanks God the less invasive pseudocystic drainage performed by endoscopic manner is also present in the data. If you're talking about the biliary stents, 1/2 of the patient got single plastic stent for solving the biliary obstruction, or multiple plastic stents, and metal stents and covered metal stents just in a small proportion. Hopefully, this means that the uncovered metal stents are not used in the benign biliary stricture caused by chronic pancreatitis. According to the data, 5% of the patients need one more or two more endoscopic intervention as well. And I'm happy to inform you as a surgeon that according to the admission paper wrote by the endoscopist, 40% of the patients, they think, I mean the gastroenterologist, need for further surgical intervention. Jump to the surgery. Among these patients, 20% of the patients was treated primarily by surgery. These are the typical surgical interventions. The early complication rate was around 2%. If I check the late complications generally, I found that in 70% there was no any pancreatic complications. These are the numbers of the possible recurrent acute pancreatitis, fistula formation, Wirsung obstruction, or pseudocyst formation. If we are talking about just the biliary complication, it means that the majority has no any biliary complication. In some cases, biliary obstruction, in less frequent cholangitis was to see. Multi-organ complications are quite rare. In several cases, multi-organ failure, respiratory failure, renal failure happened. It's interesting to compare the late complication rate according to the pancreas between the endoscopic and the surgical intervention. Almost the same numbers. The complication rate is a little bit higher in surgery according to the pancreas. Much more abscess formation and much more pseudocyst formation compared to the endoscopy. We have to check what is in the background of these data. Almost the same the situation is with the biliary late complication. interestingly, surgery has much less biliary complication, no cholangitis after surgical intervention, and less frequent biliary stricture. As I mentioned, the aim of this whole presentation was to do further refinements. So probably what can be the take-home message is it would be important to roll up the previous and the following story of the patient in order to be able to get a complete view for the diagnosis and the treatment of that patient. And it would be better to connect more hospitals representing well the treatment of the chronic pancreatitis nationwide in the endoscopic side and in the surgical side as well. Thank you very much for your attention.
The paper is open for discussion.
One thing that we haven't done, but you may want to consider doing, is just asking the patients or checking to see if they've had episodes of hypoglycemia, because diabetes in some of these patients may be due to the loss of their entire islets, including glucagon, so that they're more susceptible to brittle diabetes and hypoglycemia. And I think that's important information that we should be collecting.
Thank you, Rich. We have not enough data about that, unfortunately, but it would be important.
Peter?
I also have a comment because we were also shocked when we saw, that the diagnostic ERCP is so high. However, if you look at the financial issues, which is depend on the ministry and the NHS system, there is not registered the secretin-stimulated MRCP, not registered the secretin-stimulated EUS. Like when I visited your countries, because in the last year I was also in Russia, Romania, Ukraine, and other countries, I think you have the same problem, that many of the diagnostics issues which are now routinely done in Western Europe and America, it's not registered in our countries, and Hungary is also in this part. So these kind of registries, and this is one of the reasons why we would like to have a common voice. If we do this registry and we're showing that, yes, we are totally going to the other direction, what the other part of the world doing, and please try, please tell to the ministry that change the system. And when we can show hard data them that we are doing wrongly, they may change it. So I think this registry is the only possibility to see and to show to the NHS system that we need to change. So this is not only good for the patients, but good to have a common voice.
Is secretin available in Hungary?
Not yet.
Not yet.
Okay. And how about in other countries in Europe? Is it exported from the, like imported from the US, or is there a European country that
As far as I know, yeah.
Imported
From US.
Okay.
Thank you very much.